our Polypharmacy Project here in the South Piece will work to deliver over the coming months. So we thank you for your involvement and look forward to feedback to make these sessions more relevant and applicable to your practice. So just quick note on our disclosures. I'm a pharmacist employed by Northern Health, and I'll let Rachelle discuss hers.
Hi, I'm also a clinical pharmacist with Northern Health. I do work for the BC PAD program as well. So some of you have seen me for some other education sessions throughout your career. And just a little background, I've practiced pharmacy in quite a few areas. So I've done community pharmacy. I've also managed a couple of community pharmacies. And I've obviously worked in the hospital a few times. I'm a faculty member at the University of Northern BC, where I'm the main lecturer for a graduate level pharmacotherapeutics course. And then in interest to this topic, I am also a certified diabetes educator. So, but I do have no other conflicts of interests in regards to any of the medications we'll be discussing. So,
great. Thanks, Rachelle. So just a quick overview of our learning objectives for the sessions tonight. We will briefly describe the mechanism of action, precautions, and contraindications of non-insulin hypoglycemia medications, very briefly discuss some of the evidence related to these agents, particularly diabetes-related morbidity and mortality, and finally describe treatment goals for patients with diabetes mellitus in terms of patient-centered outcomes. And I will note that we have 2 cases that we'll be reviewing today from patients in our area, and we acknowledge that there are other medication concerns and issues with these patients, but chose to focus solely on the diabetes, particularly because of time constraints tonight, and we will identify some of these and discuss these issues in future sessions. So does anybody in the group feel like this is them when we talk about diabetes? There are all kinds of different drugs out there, and it seems like a very complicated topic. There's lots of background noise with over 20 agents for diabetes, and that's not even considering our insulins. So questions that you might ask yourself are, do I have to know all of these agents? How do I help make a decision to find the best therapy for my patient? So tonight we're hoping to give you a very brief overview, but allow you to become more focused in your patient care pertaining to diabetes. So our first patient that we'll discuss tonight and introduce is a 58-year-old female. She presents with fatigue and very little appetite. She had a recent appointment with an endocrinologist who recommended semaglutide, but the patient was very concerned about the adverse effects and the cost of this medication. So she was referred to myself as a primary care pharmacist for diabetes education and management. So a quick background about her: diagnosed type 2 diabetes mellitus. She's on gliclazide MR 30 milligrams a day, as well as glargine 42 units in the morning. Her most recent A1C at the time was 9.0, and her blood glucose levels were ranging between 10 and 20. Also has a history of hypertension, hypothyroidism, hepatitis B, anxiety, and insomnia. So upon discussing with her and looking into her patient goals and patient values, which we'll talk about a little bit further into the presentation, these were the options that we came up with together. We could introduce a low-dose metformin and go from there. We could work to increase the gliclazide that she's already on, add a medication within the GLP-1 class, something like semaglutide recommended by the endocrinologist. We have the SGLT2s, something like Paddleflows, DPP4s, for example, linagliptin, or increasing her insulin glargine. So with that, I'm going to give you a little bit of time to think on it, and I will pass it over to Rachelle. I'll just put myself on mute here and pass it over to her to chat about some of the safety and efficacy of these agents and discuss the evidence.
all right, so I'm just going to take control over here. I like doing that. All right, so thanks again and if we're now going to take a really brief snapshot of the evidence. I hope that you do understand that this particular topic, even though it's a very interesting topic and one of my favorites, it takes a long time to get through. So be aware that this is an overview snapshot. If you do have additional questions afterwards, please be free to contact me. So with that being said, we're going to start looking at these medications. So like Sydney had said, oh my goodness, there's a whole bunch of these medications. This is a snapshot of them. There are 8 classes of medications and upwards of 20 medications. Not to mention, there's a whole bunch in the pipeworks for coming out again. Now, when we're looking at medications for type 2 diabetes, we have to be aware that when they become, when they get approval for regulation, it's based off of their ability to lower the A1C. So we have to keep that in the back of our mind while we're looking at the evidence, because it does set a foundation for how things used to be studied and the type of evidence we have available to us nowadays. So yes, there is a criticism to that, but that can't change the past of how they were. Do we need to know all of them? I have to admit, I get confused too. So if you are looking at this saying, oh my goodness, how am I going to remember it? That's okay, we all do. So just remember there's lots of them, and hopefully by the end of tonight, you'll have an understanding of where some of these classes fit into your practice. So with that being said, I do want to give you a brief overview of how they would look to you and maybe a patient for you if you're considering prescribing some of them. We're probably all pretty familiar with Metformin and the sulfonylureas. So just as a brief reminder, your Metformin increases your hepatic and peripheral insulin sensitivity, whereas your sulfonylureas are classified as those secretagogues. Now, looking at the cost, so in your practice, you've probably prescribed these. And when we do look at the cost, because not all of our patients have a golden ticket type of medical plan, a lot of them will require assistance from how Pharmacare is able to assist in paying. These medications are, in the scheme of things, relatively inexpensive, right? So remember, this is all relative to your own patient that you're dealing with. Now, I have to admit, when we look at costs here, it's always most accurate for us to give a more accurate idea to tell you what the actual wholesale price is. So this does not include any professional fees, and it does not include any markups. So this is because that completely changes things. So, but in your back of your mind, when you look at these pricings, you can just assume that it'll give you a ballpark of where they are in your patient's scope of ability to pay. So Metformin is going to be about $3 a month in theory from a wholesale point of view. When we get into the more expensive long-acting agents, it drastically jumps to about $22 to $60 depending on how you dose it. Now, it's a regular benefit. If your patient's registered for Pharmacare, they'll be fine with getting access to this medication. Your sulfonylureas, about the same. They're not ridiculously expensive in the scheme of what drugs can cost. In this group, though, the glycoside, if you do ever choose to use this for a particular patient, will require a special authority, and that basically means that they've had to have failed another sulfonylurea. So that's the scheme of those two categories of drugs. These medications, just for completeness of sake, I'm going to mention them, but it depends on when you've entered practice. They did have and play a very major role in the early stages of my career, but they have fallen out of favor. One main reason is they are not covered by Pharmacare whatsoever, and the other reasons are there's just other options now these days. So they are getting a little bit more costly as well compared to the $3 to $6 wholesale. And most of your patients, though, they might not be an option simply due to the fact that they're not covered. And they do have a little bit of, they're taken more often, and sometimes for some patients, these drugs have a little bit more complicated way to take them. But most people don't, I don't see a lot of this anymore. We're not going to be able to get through a diabetes talk without talking about the TZDs. You may not prescribe them often anymore. However, these medications were really involved in a lot of the landmark trials that have shaped how we address the regulation of medications for diabetes, as well as some of the outcome data that I'll be presenting later. So I'm not going to be able to get through a talk of any type of type 2 diabetes without mentioning your TZDs, your pioglitazone and your rosiglitazone. Now, they do have some cardiovascular risks to them that had come out in some of those landmark trials that now it does make prescribing them a little more complicated because there are some paperwork that you have to have your patient sign regarding there are known cardiac risks. So pioglitazone is the one, if you do use, it does require a special authority, and rosiglitazone is not going to be covered. Now, we've got some newer medications coming out. So right? We have 8 classes of drugs, and then a whole bunch in the classes, so even more to confuse you with. We have our DPP4 inhibitors. Now what they do is they potentiate the incretin pathway. So they increase insulin release and they decrease insulin secretion. They're getting a little bit more costly per month. So when you look at these medications, they are options for some people, but sometimes the cost becomes an option that maybe limits who you would suggest them for, as well as not all of the classes, like not all of the medications within this class are covered. So your saxagliptin and your linagliptin require a special authority. The other two are not pharmacare benefits. Then we have our GLP-1 agonists, and there's a little bit of excitement coming around some of these newer medications, and when we talk about the evidence, you'll kind of see why. And you'll notice I've added a new column here. It's a column about Health Canada and your FDA indications. So these medications are now able to claim different indications for their approval process, whereas before we didn't have a lot of CDD or kidney type indications for these medications. The way that these medications are now being studied, Health Canada and the FDA has allowed them to use some different wording in their indications for them. So the trials are the capitalized letters in there. So with liraglutide, it was the LEADER trial, which we'll briefly touch on later. Dulaglutide has some CDD FDA indication, and that was from the Rewind trial in 2019. And then the SUSTAIN 6 trial was for the semaglutide. Now, we're getting expensive. So I'm not here to say which drugs, use or not, but remembering some of them without coverage are going to be very expensive for our patients. However, every patient has different goals, and every patient has a different lifestyle and quality of life type profile. So these are also medications that are getting a little bit of excitement in the world of diabetes. Unfortunately, at the moment, none of them are covered by pharmacare. So we now have our SGLT2 inhibitors. There are some more indications that FDA and Health Canada have allowed them to state, and those are through with canagliflozin. We have our Canvas trial from 2017 and our Credence trial from 2019. So as you can see, Health Canada has given canagliflozin a kidney as well as a CVD indication, and so is the FDA. Now we have our dapagliflozin, and it has an FDA indication for CVD outcomes. And with that, there was the 2 trials that I've listed there. So these drugs decrease renal glucose absorption, and they actually increase urinary excretion of glucose. Now, that's important to understand, and we will touch on that later when we're discussing how they can be applied into your practice and what type of patients may benefit from, or what type of patients may find these medications a little more difficult to incorporate into their lifestyle. Once again, they are climbing in cost comparatively to some of the options you may be more comfortable with giving. Now, only our empagliflozin is currently covered through pharmacare, and it does require a special authority. So you're probably all sitting here at, what is it, 6:15 in the evening saying, why on earth am I at another diabetes talk? Seriously, why am I here? Well, I kind of hope it's because you all miss me and you really wanted to hear me talk. And it's been a while since I've been around giving some talks about topics. But, if that's not the case, okay, hopefully you'll also have a chance to understand where some of this new evidence comes to confirm maybe what you're doing in your practice, or to maybe challenge some of your ways of applying things, or maybe you're a little confused about all the other medications out there. Maybe it's that you have nothing else to do tonight, and Sydney is a wonderful presenter, and you'll enjoy our case presentations. But either way, hopefully there'll be something that we can talk about, and we're going to give you a brief glance of the evidence so that when you go into your practice, you can maybe address what's coming up next. These moments of, what am I doing? How do I do this? Have you ever found yourself in practice sort of maybe going back through what you've learned in the past to what you now know today and say, what am I now attempting to do with type 2 diabetes patients? Even in my career, it has changed from what I was told I need to do to what I have the confidence in doing now. Then we also want to look at okay, I can't ever get through a topic of talking about diabetes without somebody stopping and saying, yeah, but what about those sugars, right? So of course, we're gonna get into how that can be addressed if your patient is adamant about their sugar levels. But maybe you're asking yourself, you know, what drives the decision making for choosing a therapy for type 2 diabetes? Or what, in my opinion, or your opinion as a prescriber, would constitute a successful treatment if I were to just overview look at that? But then we have to sit back and say, well, what are our patients' expectations? What do they think is a successful treatment? And this is where this whole talk is going to come into. Our ideas of how we used to approach diabetes, what to us looks like success, and what our patients actually are hoping to get out of that. And then, of course, everyone always wants to know, what's the best drug? Is there a best drug for every single patient? Do I really have to listen to Rachelle tonight? Or is there one drug, like all the rings for the Lord of the Rings, that does it all? Well, maybe, maybe not. So we'll get into that as well. Another question you might want to ask yourself is, what drug do I prescribe the most, and which one am I comfortable with? Because sometimes that really helps in your own decision-making process. So hopefully we'll address these types of moments. Now, I like to listen to Victor Montori. He does do a lot of work in the diabetes realm, and he so elegantly put in one of his articles what the goals in theory for your type 2 diabetes would be. And to paraphrase him, there's 3 things that we would like to do. Of course, we'd like to treat the symptoms of hyperglycemia. We would also like to reduce the risks of them having more, so hyperglycemia, so to prevent more episodes of symptomatic hyperglycemia. And of course, we're all, as practitioners, wanting to reduce risks of developing complications associated with diabetes. Now, complications could be many things, lifestyle, medical, and things such as that. So I've just showed you about 20-some drugs, and it would probably be silly of us to not try to treat a symptomatic patient, even if you're not totally convinced with the evidence. But if somebody comes to you and they're symptomatic, well, I have a whole bunch of medications that we've just showed you that can help treat that. So with that being said, that does help in some of the decision-making trees. We have those types of things available. But what else do we want to consider? Well, we always have to remember that there's that patient behind that number. And when we get into the discussion with our patient, you're going to see how that really does come into play in that real-world setting. And of course, we always want to reduce this risk of polypharmacy-related harms. Like, is more always better? Depends what we're talking about, what more means, right? Then we're going to touch on the evidence, and it's going to talk about how less intensive strategies might have an easier way to manage your patients with diabetes without trying to assume we're going to get the outcomes that we want to get, not necessarily that the outcomes that the evidence is showing that we can get. And then, unfortunately, I don't have that one drug that will fit all your patients. So systematic reviews are unable to tell us which drug will consistently give us the outcomes that we really, really want, or a patient-centered outcomes. And of course, when there's a person involved, I could show you the same profile for 2 different patients, and we'll probably come up with 2 completely different outcomes, or 2 different therapy approaches. So just remember that all of this information that you're going to hear tonight will vary depending on that individual patient with you. So I used to really be so comfortable, like Metformin all the way, right? The reason being, it's been out for a very long time, relatively well tolerated. Yes, it is more affordable. Now, I don't give a person a drug simply because it's cheap, but it is sometimes a big factor in what you would offer to a patient. Now, and then this comes out, right? We've kind of known it in the past, but it says, like, what? Metformin doesn't really have all the evidence that all these new drugs are having, so why would we even bother with it? Now, one thing to remember, though, is when Metformin came out on the market, it really doesn't have the same huge, large-scale types of trials that these new, fancier drugs have available to us. So just right there, that does change the quality of the evidence. It doesn't necessarily mean there is no evidence. It's just, or that the evidence is against the drug. It's just that we don't necessarily have the same ability to make the same decisions when we have trials that are massively, massively larger than what we potentially had in the past. Also, when metformin made it to the market, it didn't have to go through the same rigorous cardiovascular type risk outcomes that the newer medications are required to do. So with that being said, just keep that in mind about metformin. Is it the way of the dodo bird? Probably not, but there are some other medications that you may argue maybe you'd like to try in a different place in therapy. It would be nice if we could all get along. Diabetes Canada is suggesting metformin is the first line. So are the other two groups, the EASD and the American Diabetes Associations, just for the reasons that I said before. So I won't repeat that. But and then we have the ESC group, and they're saying, you know what? We're going to change it up a bit, and we're going to say that these SGLT2 inhibitors or GLP-1 agonists could be options for first-line therapy. And of course, that throws everyone like, what's going on here? Remembering when we do have a chance to look at this data that's coming up, you'll see where it comes into play. However, the interesting thing that you might find now with these medications is that not just diabetes educators or people focusing in their career area of diabetes are looking at these medications. They're starting to expand into other fields, cardiac and renal fields. So there is a lot more talk about how these medications fit in. So why can't we get along? Well, you know what? We probably can. If we just maybe ask the patient, like, who are we trying to get along with? Remember, we have a patient. So if we get along with our patient and really try to focus on what their needs, what their goals are, and how to apply the evidence that we're going to talk about into the life and the livelihood of our particular patient. So remembering that this whole goal and this push of sugars levels or A1Cs are surrogate markers. There's a really excellent older article by the TI group that does talk about what happens if you put a lot of your faith into only surrogate markers. It's a really good article. But in reality, we want to acknowledge the limitations of what the evidence is allowing us to do. It doesn't necessarily mean we can't do things. We just have to have the understanding so that when we explain something to a patient, we're able to explain the why. Why are we doing this and how we expect the medication to potentially work and things such as that. So that patient-centered approach is where we want to look at. And then we want to look at this range versus target, right? So is there a broader picture here than just telling our patient they have to hit something? So we want to focus on that whole patient safety, cost, and of course, any risks to do with polypharmacy. So we could talk to our patients. I'm sure we all do, but we could really now be able to apply what their concerns are and use how our understanding of the evidence to help find a regimen that works better for them. So I can't really get through a talk and talk about the evidence without showing you some of the guideline recommendations. So just be aware that they don't all get along. So they're not all identical. Not every group has the same recommendations at all. So in most people, the A1C of less than 7 is sort of what Canada hangs a bit of their hat on. And then they say you could go lower depending on your patient's profile. The Americans are saying, you know what, we're going to kind of stick to this range of 7 and 8 and kind of work within there. And then they said, you know, if we really want to get intense, we can go a little bit lower than that. So they're not even on the same page, and we're right next door neighbors. Now, they do have, this is just for completeness of this little bit of discussion here about guidelines. So they do change their targets depending on the particular patient. And we're going to look at why some of that has changed from the past, where it used to say, you got to do this. So with that being said, when I'm talking about how this intensive control versus less intensive control, what does that mean to our patient? And what can we do to get that? Or what should we expect if we really try to only look at what we're told to do? So we're talking about intensive A1C control here for this slide. Now, some of the landmark trials had looked at, you know, what happens if I go really, really aggressive trying to get these magic numbers. So we had the Accord and the Advanced trials. And this is where some of those trials that I was talking about, where the cardiac risks for your TZD showed up as well. We did realize, though, just as a brief summary, if you want to get more detail, you can talk to me a little after, but as we went lower and lower, we actually started really harming patients. There was, some of the trials were stopped early due to very unfortunate outcomes such as cardiac deaths and things such as that. So we did learn a lesson. You know, sometimes low is not always in the best case scenario. So a less intensive strategy when you're reading the literature is about a goal of maybe 7 and 8. Not necessarily a perfect number, but somewhere in there. So what I usually try not to talk too much number needed to treat. However, what if we have that patient who is obsessively obsessed with telling you that they need to get their numbers down because, I don't know, maybe someone at Thanksgiving told them that, or maybe that they've watched a commercial that says they have to monitor their numbers. So in theory, remembering if we aggressively treat, we potentially might be able to reach a patient's a goal of getting a lower number, but we're not really getting massively beneficial certain outcomes. Anything that you see here on this chart with an asterisk is an outcome that sometimes your patients are really involved with hoping to get, but you have to understand that the way that the studies were designed and given, there are some methodological issues with them, and they're not really considered higher quality evidence, and that would be a discussion for a whole nother day. But just to understand that, yeah, we potentially could get to these numbers, but look what's going to happen first. So we're talking 5 years of somebody taking, you know, a multitude of medications and potentially getting one of these benefits, or within 1 year, for every 30 people, I'm going to cause a very serious event. So we have to balance that. So there is a potential outcome that we might be looking for, but we have some very known harms. Now, but if I wanted to get to that number, like let's say somebody still says, I have to get to this number, what can I do? Well, it's going to be a lot of work. When we're looking at how to get medications on board to a patient who will get that down for us, we have to understand that that's going to be a lot more than a monotherapy. And considering this group is about polypharmacy, your ears are burning right now because we're trying not to add multitudes of medication. In theory, a monotherapy will give you about an A1C reduction of 1%, and as you add a 2-drug combination, the way this was studied, be aware that it's added to Metformin, just because of historically how it was done, that you might get an additional 1%. So think about what we're doing to our patient by trying to go beyond that. There's going to be a lot of things occurring, a lot of complicated regimens, costs will go up, burden will go up, and a bit of confusion. And I'm probably going to get one of the outcomes guaranteed, but it might not be the one I want. It's probably going to be a hypoglycemia, or a very serious harm. The other thing too is, well, if I'm doing this, do I have to maximize the doses? Do I have to give them multitudes of medication with maximum dosing? Interestingly enough, we have realized that that's probably not going to give the benefit that we want. Our standard dosing, as I'm going to show in the next slide, is going to give you about similar A1C outcomes as your maximum dosing. So these are just some really interesting, I picked and choose just for the simplicity of this presentation, but as you see here, a metformin doses of over 2,000 milligrams, that's like 8 pills a day, roughly. And if we compare to 2 pills a day, about 1,000 milligrams, we're getting a negligible, in my opinion, A1C change of about 0.26%. So really, 8 pills a day, think of that versus the 2 when we're looking at that whole picture there. Another couple examples are with your Paddleflows, and a difference of 0.06, with big doses versus not so big doses there. And my really interesting one is the liraglutide of 1.2 milligrams to 1.8 milligrams, where it's going to cost your patient a few $1,000s difference for no noticeable A1C change, but a much more complicated. So our goal here is to make sure we're not overwhelming our patient with polypharmacy in this attempt to grasp at outcomes that are not necessarily certain yet. So we don't want to overwhelm their ability to cope clinically. We don't want any psychological burden or any financial burden. So what's the worst that can happen? Well, you know, a severe event is actually the worst that can happen. So frequent, you don't need a lot of hypoglycemias, but you just need that one dangerous one that occurs. So we are, by trying to grasp at getting everyone to this number, or adding, we have to be aware that there are some serious harms involved there. So we have a little prescribing. I'm only going to be talking about the newer medications here, so for the last 3 categories, and then I'm going to quickly get into the evidence here. If you do want more information about this, please contact me. But the DPP-4 inhibitors, there are some contraindications here that I've listed in red. They're still new. All of these medications still have some evolving safety profiles. We have our GLP-1 agonists, so you just want to be aware that there's still that concern with some pancreatitis and pancreatic cancer. We don't recommend it in patients with inflammatory bowel disease, and it is contraindicated if people have some thyroid cancers and things such as that. Remember, these are not complete lists. Just for the purpose of the presentation, I kind of picked and chose what is a little more interesting or applicable to this group here. Now, our SGLT2 inhibitors, there's a volume depletion. Remember how I said it flushes out the urine? Well, it takes volume with it as well. So be aware of orthostatic hypotension and things such as that. Or if you have other medications on board, like your loop diuretics and things such as that, be very careful where that is sometimes an unknown harm that we could do. These medications, because they flush medications out through the urine, be aware that you're going to get a little bit more infections in the genitourinary system. So we get more yeast infections, more UTIs and things like that. There's also just some issues that we're going to look at involving your DKA risks, and I have a slide or 2 for that one. So where is this evidence, and why did these medications get some different indications? So I'd like you to be aware of, here we go with, it all started with the EMPERAG trial. So back in about 2015, it showed that the medication Paddleflows was able to decrease CV death in people with type 2 diabetes and CVD. So it started getting a lot of attention. So then, of course, every new drug wanted to add to their indications. So then we got the LEADER trial in 2016. And basically what this one did is it was able to show that patients with type 2 diabetes with an increased risk of CVD, the liraglutide was able to demonstrate a reduction in CV events compared to placebo. That's exciting. So people are now, wow, these things might have something to it. And then we had canagliflozin. They're like, well, we're not getting left out. We want to try to have some new indications as well. So we have trials such as the Canvas out of 2017, and it was with patients with type 2 diabetes who were at high risk for CV events. The canagliflozin was able to demonstrate a reduction in the rate of renal decline and heart failure hospitalizations versus placebo. So it also showed a decrease in MACE, which is major adverse coronary events with people with type 2 diabetes and CVD. And then we have the DECLARE trial for 2019. So we're getting quite recent now here. And basically DECLARE it didn't really show a decrease or increase in MACE compared to placebo. So it was neutral in that setting, but it was able to demonstrate some reductions in some of the other primary outcomes, such as CVD death and hospitalizations for heart failure. So once again, patients and doctors and prescribers are getting quite excited about these medications. Credence came out, and it's a kidney type trial. So it showed that canagliflozin, so one of these flozin groups, was able to show a reduction in the composite outcome of end-stage kidney disease, doubling of the serum creatinine baseline and from baseline, and then death from renal or CV events compared to the placebo. So some critics are saying that this one was stopped because it was stopped early. We may have an overestimation of the benefits, but there's some positive signaling coming from a few of these medications. And then recently we have the DAPA-HF that showed some heart failure type benefits. So it's getting people quite a bit excited about these medications. And then when I was making this presentation, I realized that the DAPA-CKD trial is not quite yet published, but it's also looking to get some more data for chronic kidney disease. So these new drugs, what are they all about? Do we have something here for us? Is it maybe quite a little bit of exciting depending on the type of patient we have? And now you can see why other disciplines are starting to, you know, put an ear down and start listening about diabetes medications, because, oh, well, is dapagliflozin a diabetic drug, or is it more of a CHF drug? Or, you know, where do we place this medication in the whole scheme of things? Right now, the mechanism isn't fully understood, but, you know, these are things that you might notice other disciplines starting to prescribe as well. Then we have our canagliflozin, which is helpful in patients with diabetes with some renal impairment. So that might be another option for some of our patients if we're really thinking down that line. And then the benefits are there. They're appearing to be there. They're signaling that they're there. They're small at the moment, but hopefully we're heading our diabetes research in the right direction, where, who knows, maybe we'll completely hop the fence and start a whole new way of how to investigate the outcomes for diabetes. And that it's getting quite exciting and reasonable, because in the past we've had nothing like that before. So we now have a lot of things that we can help with our patients. And these newer drugs may be an option in some patients. I do have to show this. This is rare, but it can be life-threatening. So just remember, with the SGLT2 inhibitors, we can have some DKA that occurs, and it did get an actual warning. Therefore, just be aware the one thing that sometimes might throw you off is at the near normal glucose levels. Because remember, the drug is designed to reduce that A1C, but it does have some other metabolic processing going on that you could get a DKA involved. So just be aware that in those patients, if you're prescribing their meds, super exciting, but we can't lose sight of the fact that, you know, if there's an effect, there's sometimes a side effect to be aware of as well. So I'd like to think that we're moving forward with some cautious optimism. Is more better? Well, it depends. More what, right? So more involvement with the patient? Absolutely. That's absolutely better. More drugs? Probably not. As you've noticed, more isn't really giving us the magnitude of benefit that we thought it might give. More investigations happening? Absolutely. That's really exciting. But adding drugs and really increasing dosing strategies for that is probably not going to give us consistent outcomes that we're looking for. Now, these newer medications are really offering some really unique opportunities for further investigation, and they do show quite a bit of promise. Remember, there is a substantial cost, and we still have an evolving safety profile with them. So we do have to strike that balance, like which particular patient is there with us, and how does their lifestyle revolve around what that evidence is showing us. And diabetes used to be really overwhelming, but now I'm understanding that the evidence is we could probably do some of this, but it's not likely that we're gonna, you know, tell them we can do this, 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 or this, or it's not likely that we have to now say, if you don't take your medicine, blah, 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 blah. So it's actually it's less overwhelming now, knowing that with the evidence that we have, we can guide our patients into something that fits their lifestyle better without us fear-mongering them. And so that impact on our patients' lives. So it's not necessarily what drug to add, it's if we're going to be adding something. And we do have to embrace that uncertainty. We really don't know all the answers. And to pretend we do is going to be a bit of an issue. So as you can see, telling our patients that these drugs will do that is a little uncertain at the moment. We also know that if we're focusing only on A1C and driving drug regimens with lots of drugs, lots of dosing, we're likely not going to get the outcomes we're looking for, but we're probably going to cause a harm here. So, and even adding more isn't necessarily dropping those numbers. We do have potentially other reasonable options for some groups of our first-line choices. So metformin, probably great for a lot of patients, depending on how you historically like to approach your diabetes patients. Also, though, there are these SGLT2 inhibitors as well as your GLP-1 agonists that could be reasonable depending on that particular patient. And then remember, right before I send it back to Sydney, that patient-centered approach, looking at the evidence and applying it to that person from a safety point of view, a cost point of view, and that medication burden. So thank you so much for listening, and I'll send it back to Sydney and we can discuss our patient.
Thank you. So taking it back to that patient that I introduced earlier, I wanted to open up to the audience to get some thoughts from them. Do you have a medication you would typically go to or recommend for this patient? Do you have additional questions that you would ask this patient to help tailor your therapy and have that conversation? So we'll open it up for a couple minutes and get some discussion going.
Ulrike here. I think I would go and focus on lifestyle and would go in depth some exercise and explain to the patient how diabetes is caused by insulin resistance, and insulin resistance is driven by insulin, and how she can change by diet, intermittent fasting, increase exercise, get a good result, and you could reverse diabetes. Like if you give them that outlook, it's quite amazing what you can actually achieve without medication, right? Or not adding any medication. I think it's better to motivate the patient and educate what in their lifestyle has driven them to become diabetic, because it takes 10 years to be diagnosed with diabetes, and you have insulin resistance way earlier. So it's good to do a fasting insulin, and you should sit around 30 with your fasting insulin. And the upper norm, I think, is 180, but some already are over 200 with their fasting insulin level, not officially diabetic, because the insulin is still making sure that they can get the glucose in the cells. But if you take the time to explain not to have any processed food, no soft drinks, and in North America, we tend to sweeten ketchup, all sorts of products with corn syrup. And there's this poor fructose, which is, it's poison, right? Because only the liver can process it, and you get a fatty liver at the end. And it gets transferred in triglycerides, and then you get obesity. So there's lots to it. But I think if you explain it in depth, that you can avoid medication or make it maybe one tool, but not the main tool, and have the goal to reverse if the patient is motivated.
Absolutely, and that's keeping that patient-centered focus in mind, that we're not all about medications. And you'll see in a video clip from a patient here shortly describing that perfectly. Thank you, Dr. Meyer. Any other thoughts from the group on where they would go?
Hi, Sydney. It's Charles here. I'm just going to stick my neck out here and say that it makes absolutely no sense for this kind of patient to be on both gliclazide and insulin glargine. The gliclazide is basically a secretagogue, so you're like flogging a dead horse with flogging the pancreas here to produce some remaining endogenous insulin, plus you're giving extraneous insulin, more risk of hypoglycemia and other complications.
Absolutely.
You've got to ask why this patient is on such a large dose of glargine in the first place, but the combination, patient here on 2 drugs, both of which are putting her at risk for hypoglycemia. But the trouble is, one sees this a lot. This is not a unique case. This is a very common scenario, and it's asking for trouble.
Excellent point. I think we have time for one more comment if anybody else wants to jump in. If not, I can let you know what happened.
Sydney, what was her A1C?
A1C was 9.0. But the key is here that she was symptomatic. And again, as Rachelle mentioned, not that target treatment, which is important for us to note. So we walked through the different options, the patient and I. So we talked about Metformin, that we could consider a very low dose and a very slow titration, but the patient had tried that in the past and had a history of pretty significant GI reaction, and she was against using that, which is completely fair. We have to respect those patient wishes. We talked about increasing the gliclazide. The patient's on a pretty low dose with room to increase, but just as Charles was saying, it's likely not providing much glucose lowering because of the mechanism of it and the safety concern with hypoglycemia. So that wasn't an option we were keen on. We looked at the GLP-1s, the semaglutide that was recommended by the endocrinologist, but this patient didn't have coverage, and it's not covered by Pharmacare. So this cost at a couple $100s a month was a significant barrier to her. And she did not want the appetite suppression and the GI side effects, especially with underlying appetite issues. Next, we talked about an SGLT2. The patient did tell me that she was on dapagliflozin in the past and did have a yeast infection, but she was willing to trial a low dose again if that was an option that we had to do. Next up was the DPP-4s. I found out she had had a history with saxagliptin, and at that time her blood glucose and her symptoms were pretty well controlled. but she was taking that saxagliptin in combination with metformin, and the metformin was giving her GI issues, so the whole pill was stopped, and it was never reassessed for the DPP-4 to be added back in. And then finally, we talked about increasing that insulin. The patient was hesitant about this because of that weight gain that comes along with insulin, and she preferred to try out other options first, which we thought was completely reasonable. So for her, we stopped her glycoside, started her on linagliptin. The patient still remains symptomatic. Her blood sugars, although they've dropped, are consistently 10 to 15, better than the 10 to 20, but it's still that patient's symptomatic. So it's something that we're working toward. And her next option was to decide to work to titrate that basal insulin. So that's something that's currently in progress. So we ask ourselves, what about this target focused therapy? We want that A1C under 10. We want those fastings between 4 and 7, the postprandial between 5 and 10. But as Rachelle was saying, we really have to think about that balance, that patient preference, their quality of life. And the big question is, rather than which drug next, is if we're going to add a drug next. So we'll jump right into case number 2, and we can talk about patient number 1 in more detail at the end if anybody has questions or comments. So our second patient was a 67-year-old female referred to myself in December of 2019. She had ongoing fatigue, headaches, described it as a brain fog, and a lack of energy. And it was thought that this might be medication induced. And she had seen a naturopathic doctor because of these symptoms, but had no results. Her background here, a little bit more significant than our first patient: type 2 diabetes, on glycoside 80 twice a day, glargine 20 units in the morning, 50 units at bedtime, and a Lispro sliding scale. Her A1C was 6.1. Her blood sugars were ranging from 2.8 to 10.6 in the last month, with very frequent hypoglycemia, mostly daily. Had a cardiac history with an end-STEMI earlier in that year, insomnia, thyroid issues, and some supplements and things like that she takes as well. So upon discussion with the patient, we determined that it was her frequent hypoglycemia that was leading to a lot of these symptoms. And when we look at Diabetes Canada and see this nice infographic about all of the symptoms of hypoglycemia, it fit this patient profile perfectly. The patient was extremely concerned about long-term consequences of diabetes. She had many friends and family members that had died or had very significant complications of untreated diabetes. And she was very anxious and strived for these textbook targets that Rachelle was describing earlier. So over the next months, we worked to stop the Lispro, drop the glycoside, and reduce the glargine by almost half. And this is an example of her blood sugar log. So back in March, we can see with the red circle there that she had some 9s, and there are sad faces beside that. She's quite upset and discouraged about this. We see later on in the month, she had an 11, another 9, and wrote no more and got very frustrated. And then later in the month, she stopped testing her blood sugars for about a week. So this is not a way to help us set up our patients for success and help motivate them to keep their treatment going and to help take control of their situations and of their conditions. So it's really important that you do that education to get the patient to understand the safety risks that come along with that. And although we might not have the evidence that tells us where those numbers need to be, it's all very patient specific and determining those targets with your patient in mind. So I saw her last week. We did another medication review to look at some of the changes to her list. So for her diabetes, her glycoside and insulin Lispro were dropped. And as I mentioned, we dropped her Basaglar by half. We added a couple medications. She had a recent diagnosis of depression. She decided, just because of pill burden, to drop a lot of the vitamins and supplements that she was on, and is working very hard to reduce the sedatives that she's using for insomnia. So she's now down to 3 nights a week and has dropped her trazodone significantly. So this is great progress, not just diabetes related, but polypharmacy and deprescribing in general. And with that, I just wanted to bring it full circle and remind us as a group that diabetes care and patient care in general should be patient-centered. So keeping in mind that safety, the cost, the medication burden, the adherence, and the quality of life, that we're doing all of this for our patient. And our patients really want to be involved in that decision-making process. So walking them through as the healthcare experts about their different options and what might be the best for them, and then allowing them to make that final decision. And explaining your rationale for changes. I find patients are always very interested to know why I've chosen or encouraged them to take a drug or a regimen or made a suggestion in general. Patients want to know. And then back to Rachelle's comment earlier, just embracing that uncertainty. Nobody knows what the best diabetes drug or best diabetes care is out there. We have to use our judgment as healthcare providers and keep that patient in the center of the circle and in the center of our care. So with that, we'll open it up. We've got a few minutes left for some discussion or comments or questions. And I want to thank you all for joining tonight.
I think the last patient you presented was a prime example of a highly motivated patient, right? If you would have given her the time to maybe explore her lifestyle, why did she become a diabetic at age 30? What was happening in her life? To go just back, was it pregnancy-induced diet? Who knows? Stressors in her life. But maybe to just wrap it up from the beginning, and then maybe I have good success with the diabetes code. It's written by Dr. Jason Fung, an internist from the States, but it's so well described diabetes. It's a good read for physicians too, I find. And he repeats this message, but patients really get motivated and have someday off medication, or they are prevented to go on insulin, or get their number from 9 down to 6.9. It's just amazing, right? With that approach. And if you give them the education, I think there's lots we can prevent and really reverse diabetes too, I think, before they're on insulin, because it's an oxymoron to put a type 2 diabetic on insulin.
Sydney, would it be appropriate if I kind of spoke to this as the dietitian that was involved with this patient?
Absolutely. Okay.
So actually, in this particular situation, I became involved when this patient, some regular members of her care team were away, and so she reached out to me for support, or actually it was the community paramedic who did connect me with her. When I did a brief kind of informal assessment with her, it turned out that she was actually exercising. She was walking for up to 3 to 4 hours a day, and she was actually dieting. She was on a very, very calorie restricted diet. I would estimate likely no more than 1,000 calories per day. And this was at the peak of her severe, very dangerous hypoglycemia. So for her, I guess it's important for us to know that while we make these suggestions, and sometimes we might overshoot a little bit with the lifestyle stuff, because we know that sometimes patients don't always follow through. There are sometimes going to be that person who takes what we say and they challenge themselves to do even more. And sometimes in rare occasions like this one, it can actually be quite dangerous for the patient. So yeah, it always really is so individual just to the patient and the person behind the treatments and their past life experiences. So I think it was quite anxiety motivated for her. So yeah.
Thanks, Sarah.
Sydney, I just remember at one of the 3D conferences, our keynote speaker saying that diabetes is a lot more than just raised blood sugar, and we focus so much on bringing the blood sugar down, and we're not necessarily affecting the other elements of type 2 diabetes. And maybe that diet and exercise, to follow on Ulrike's comments, potentially deal with the whole diabetic picture more than the medications do in terms of just reducing the A1C. So the easiest thing for us to do, and it follows on what your patient said in that interview as well, is just, here's your prescription, here's another pill. And the kind of education we need to working with dietitians, etc., but the kind of, it takes a lot of time to actually get to the point where they understand or they follow through with the exercise and lifestyle and diet prescriptions that we give. But those things are probably more important, in my view, than the medications for those reasons.
Absolutely. And I always start my conversations with patients when I see them for the first time with diabetes that diet and exercise and lifestyle are going to have so much more of an impact than any medication we could give you will.
It might be also with the last patient, your example, that she was doing really a superb lifestyle and her insulin doses were not adjusted, so she became severely hypoglycemic. I think if that would have been done as a team approach with the pharmacist involved, with the dietitian involved, the physician involved, if their insulin dose had been lowered, she wouldn't probably have gotten that hypoglycemic, right? That might be one point where she restricted her diet to certain calories and walking 3 to 4 hours. That's quite intense, right? So, and maybe was over medicated, and that was the side effect that she got hypoglycemic.
Absolutely.
Sydney, yeah, she's an interesting patient, and I totally do agree. We have to be patient-centered, but I think you have to give a patient a certain target as well. Like in this case, this lady had already existing coronary artery disease. She has all the potential side effects from long-standing diabetes, diabetic retinopathy. This lady is high risk for stroke and heart disease, as we have already seen. So I agree you have to be patient-centered, but you also have to you must work towards a target for this patient. Yes, she was maybe a little bit OCD and overcompensating for, with her blood sugar levels as well. But, like in this case, you can't say to this lady, well, I don't want to be on any, I'm going to follow just how you feel about the medications and we're going to run for A1Cs of 9%. You cannot do that. So I think it does come in, we have to sit down and explain to the patient. But I know this patient and she's had quite a number of other issues as well, because if you live with chronic disease for 35 or 40 years, you are going to develop some other mood disorders as well. But this is a good case, but I do believe you still have to be aggressive in a patient like this with existing coronary artery disease and end organ disease. You have to be aggressive in lowering, and it's not. She has been following the lifestyle management, which is fantastic. But I do think medication in this lady plays a significant role. In order, you have to target something here. You cannot leave this lady and say, well, we're going to leave you and let your A1C shoot up to 9 or 10%. She's going to have a stroke within a year from now. I can guarantee you that.
And absolutely, it's creating those new targets for this patient. Basically what you were saying today, earlier this week, I had a patient who's had an A1C of around 13 for the last couple of years. And he told me his preference was he doesn't care about the long-term consequences. He would rather live the day-to-day life. So as healthcare providers, it is difficult to go against what we know in our training and what we know will happen to the patient if they're expressing that's what their wishes are. So it's kind of an ethical dilemma there, but we have to do our part to educate them, talk about some of the consequences, either of over-medicating or under-medicating, and let the patient make that informed decision. And I know it's very hard to step back and do that.
Dr. Ventura, with your comment, yeah, exactly. Like there are a lot of things that we have to consider. So being the nerd that likes the evidence and things such as that, it's kind of exciting. We potentially have other classes of medications that we could now potentially think for that type of patient, whereas in the past we really didn't have anything to offer to them. So now with the investigations coming with some, CVD outcomes and some kidney outcomes, we might be able to broaden our ability to look at patients specifically, like you're saying, right? It is sometimes nice to say, oh, you'll be fine, because let's just let you decide what you want to do. But now, in the past, we really didn't have medications or options or any evidence pointing that if we added more, we could benefit that patient in those outcomes. Whereas maybe potentially now we do. So with that particular patient, like you said, yeah, we can't just ignore everything for, rainbows and smiles, but it is exciting that the way that the evidence is now going and how investigations for medications are coming, that you as prescribers might have just a little bit of other options for patients that we didn't have before.
Hi, it's Debbie here. I just have a comment about our second patient there, and of course too, because she's from our area, we've each had a chance to know her. And since I originally met her quite a number of years ago, she'd really changed, and she wasn't ready at all to accept any chronic disease. She's, yes, over the last so many years, really taken the bull by the horns, and then of course it's swung into all the hypoglycemia. But I guess just what I see in that case is how progressive type 2 diabetes is. And like Dr. Helm said, it's massive. It's more than just hyperglycemia, which I know you all appreciate. And so again, just as you've all said, it's to look at those patients individually. And she really has come a long way working with Sydney, and it's taken a lot for her to come to some acceptance of not pushing those sugars down into those low numbers. But I think she's slowly getting there and coming to grips, so that's really good to know.
Hi, Dr. Perry. I'm just reading through your comment now about considering one of the newer agents for this lady. And that's something we did investigate. Dr. Venter and I talked about using an SGLT2 for this lady and possibly getting her off of the insulin and some of the concerns that come along with that. But she had, again, had a bad experience with a UTI from an SGLT2 inhibitor in the past, and again, wasn't open to that. But it's an ongoing discussion and something that we can always work towards and reintroduce in the future to see if the patient's agreeable to it. And then Christy had a comment. I can read it out, Rachelle, if you want to address it. It was my understanding that we need to be careful when decreasing a patient's A1C and glucose levels too quickly, as they also run the risk of adverse effects from that as well. Do we have a goal of how slowly or quickly to do this? If they say their average is 15 to 20, then dropping them to 7 to 10 with medication changes, if that makes sense.
Okay, so there really isn't evidence to completely address that in a sense, but of course, if you look at how the medications work in theory, it's unlikely that you're going to get massive drops based on the literature. However, of course, someone's going to say, look, Rachelle, I've had this patient that this has happened to me. But you have to understand too, sometimes people, they're either very used to operating at a very high level of their A1C, and other patients are very adapted to operating at a very low level. So doing anything in this type of setting drastically isn't really in the best case scenario as well. And these things do take time. I wouldn't want to completely drop somebody who's an outpatient that quickly. You can, patients they have maladaptive procedures that, if you're used to operating at something like that and you drastically drop them, it's going to be a little bit more complicated than that. But yeah, you don't want to do anything extremely drastically in that case, but there are ways to address that with the understanding of which mechanisms or which drugs are capable of doing that. But even as you saw the evidence, adding medication upon medication, you're not getting 10 to 15%, massive drops like that. It's about 1% adding something else. So, and depending on the one that you might choose, there are dose-related harms. So you have to consider that as well. So yeah, our goal is to maybe get them less symptomatic or into a more comfortable range that we want. But does it have to be overnight? Probably, I don't think so. Maybe Dr. Perry he does have a little bit of different insight in that. If he wants to chime in, that'd be wonderful to hear his opinion on that. But I don't think I would do it overnight or anything like that. It will take a bit of time, and you have to adjust for their ability to cope with how you're doing that.
There's just a comment here about sharing the slides, and I don't think we'll be sharing them for this session, but the video recording is available, I believe, through Charlie, if people want to request that to see the information again. And as Rachelle mentioned earlier, she's happy to do academic detailing sessions with people in the region if you'd like more information.
Yeah, Rachelle, it's Tom Perry here. I was doing a good job of keeping my mouth shut, I think.
And I love hearing from you.
But, well, just from an internist perspective, or I think a general medical perspective, when people are really symptomatic, then of course it's desirable to lower glucose promptly. But it's a rare phenomenon. Well, unless people are completely devoid of medical care. I guess it's not rare in the US, for example, but it should be rare in Canada. Maybe in your part of the world it's hard, and there would be very poor people in the Lower Mainland, or perhaps immigrants who don't function well in English, but it should be a rare issue. And then the issue of whether you can prevent any complications, it's not going to be a rapid process. If anything prevents complications, it's over years at least, and decades more likely, with almost never any. I can't think of what the exception would be. If you're very severely hyperglycemic and become dehydrated with hyperosmolar state, you can die in hours, so that's an emergency. But actually getting water in is much more important than getting the glucose down.
Thanks, Dr. Perry. So Charlie just sent a message there. You can reach out to her if you'd like to request the recording. And just a reminder that that evaluation link is there, which is required for the physician CMEs. And we'd appreciate any insights and feedback that you have to make these sessions more applicable moving forward. But we hope you enjoyed tonight's session, and thank you for your participation.
Yeah, thanks everyone for giving us your time tonight.